Hello everybody, I am Dr. Santosh Kumar, orthopedic surgeon based in Kolkata. So in our previous videos we have been discussing a lot about various types of joint replacements, models, and what are the causes which lead to joint replacement, how the recovery takes place, and various other modalities pertaining to joint replacement. So in this series we have started discussing the questions that you have been sending us, and you can further send us the questions to santdr@gmail.com. This is my mail ID, or you can WhatsApp me at 9831911584. So you can find the details later on also, and you can send your questions, queries pertaining to arthritis, joint replacement, and all those issues, and we will be discussing them one by one. So today we will be discussing several questions that you have been sending me. Now, see, the whole idea of doing a joint replacement surgery, whether it's a knee replacement or a hip replacement, is to restore painless and stable movement, and thus to restore the joy of movement. Like all of us have been moving and all of us keep on moving, so we take it for granted. We take our locomotion for granted, but only when somebody starts suffering from pain while movement, somebody whose movement is restricted, then only we tend to realize how important is this movement, because life is movement and movement is life, and we are committed to restore the joy of movement and to restore the movement in life. So we'll be discussing the questions. Well, any joint replacement is done for end stage arthritic disease. Similarly, knee replacement is done for end stage knee arthritis. Now, this arthritis develops over a period of time, and it can be various kinds of arthritis, like it can be rheumatoid arthritis, it can be osteoarthritis. Most commonly what we get is osteoarthritis or rheumatoid arthritis. So osteoarthritis is wear and tear of the knee joint. The way our car tires wear out, similarly weight bearing joints in our body wear out, and knee joint also wears out. So this arthritis is known as osteoarthritis. Now this can be of two types. One is primary, which is age-related osteoarthritis. Age-related osteoarthritis. This is something which all of us will be subjected to. And second is wherein there is a definite cause which accelerates the osteoarthritis, like a trauma, fracture, or a ligament injury, etc., etc. So that is secondary osteoarthritis. Age-related osteoarthritis generally takes place in both the knees, and along with osteoarthritis we have several cases of rheumatoid arthritis, and sometimes rheumatoid arthritis starts pretty early in age, which is known as juvenile rheumatoid arthritis, and that can start somewhat around 15 to 20 years of age also. Sometimes there is ankylosing spondylitis which affects the knee also. So all these things are there, and whatever may be the reason, the end stage of arthritis is the destruction of knee, which causes pain, stiffness, and instability. So basically there are 3 or 4 features of this end stage arthritis. One is persistent pain, second is instability while walking, third is stiffness of movement, that is straightening and bending is very painful, and fourth is bending of the knee. This bending of knee is more obvious in rheumatoid arthritis as compared to osteoarthritis, but in all sorts of end stage arthritis the knee generally bends, the knee is no more straight, and that itself leads to instability. So that bending can be in 3 directions. One is inward bending, which is known as varus knee, other is outward bending, which is known as valgus knee, and another is folding onto itself, which is known as fixed flexion deformity, and sometimes it can be in hyperextension also. So these are all features of end stage arthritis, and in these cases knee replacement is needed. So basically knee replacement is for advanced arthritis, end stage arthritis of knee joint, which causes pain, stiffness, and instability. Now this instability is a major factor, major problem, because instability leads to fall. All our like senior citizens who would have fallen indoors, low velocity trauma, indoor fall on floor or fall in bathroom, they have, most of them would have happened because of knee arthritis, which has led to instability. So knee instability leads to fall, and hence fractures like fracture neck femur. So that is the bigger picture of knee end stage knee, advanced knee arthritis. It's not only about pain, it's about instability, disbalance, there's a risk of fall, and hence fracture, which is the bigger problem. So in all these cases we need to think of knee replacement. Knee replacement is bound to restore painless and stable movement. It will restore stability and it will restore painlessness. Hence, knee replacement is a life-changing surgery, promotes the joy of movement, and a person is able to go back to his professional, social or personal life and activities of daily living. So, knee replacement is done when knee arthritis starts affecting one's activities of daily living or one's social life or one's professional life. So, knee replacement is a very predictable surgery and it gives a life-changing results and restores painless and stable movement. We have already discussed what is osteoarthritis and what is primary and secondary osteoarthritis. Yes, knee replacement is basically a surface replacement and realignment. What it means is that in any knee arthritis, whether it is osteoarthritis or rheumatoid arthritis, the cartilage is destroyed. That surface is replaced by prosthesis. That is what is knee replacement. So, knee replacement is technically resurfacing and it is realignment. What it means is that bending deformity of knee joint is corrected. So, this is resurfacing and realignment, and hence, of course, it will cure any kind of knee arthritis. We have discussed the benefits of total knee replacement is restoration of painless and stable movement, and thus enabling one to do the activities of daily living without any hindrance, without any problems. So people with end stage arthritis of knee or advanced osteoarthritis of knee, they have difficulty in their activities of daily living also. It starts first with difficulty in their social life, professional life, then it starts activities, then it starts affecting the activities of daily living. For example, person is not able to walk indoors, person is not able to go to washroom, take care of himself or herself. So knee replacement will restore painless and stable movement and enable one to carry on one's activities of daily living or social life or professional life. So these are the benefits of knee replacement. Well, there are various recent things that have taken place in knee replacement, like the alloy cobalt chrome along with the traditional cobalt chrome alloy, titanium niobium has come out. Then there is rotating platform knees, there is low contact stress knees, and there is personalized instruments which is known as custom fit instruments, there is computer navigation, there is robotic surgery. So all these developments have taken place. But the single most important thing that determines the results and the longevity of the knee implant and the performance of the implant is precision, 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 and hence it is the surgical expertise and hence the surgeon. The single most important thing which affects the results of the surgery is the surgical skill of the surgeon and the motivation of the patient. The patient should also be motivated to do exercises to recover fast. That motivation is also very important. So two things which are most important for the good results of knee replacement is the surgical skill of the surgeon, the precision of the surgeon, the expertise of the surgeon, the experience of the surgeon, and of course the motivation of the patient to go back to normal life. So these things take a preponderance over any recent technologies. Like these things are more important than robotic or computer assisted or whatever it may be. Well, partial knee replacement is wherein the only inner half of knee is replaced. So partial knee replacement, normally the knee arthritis starts with one of the compartments which is known as the inner compartment, which is technically known as the medial compartment. So medial compartment arthritis, or let's say in technical word it's called anteromedial arthritis. When there is isolated medial compartment anteromedial arthritis, what it means is that when the arthritis is in very early stage and the knee has not bent, there is no significant bending of knee, then we can do partial knee replacement. There are certain criteria for partial knee replacement. Not everybody is a candidate for partial knee replacement. For example, the knee should not be bent too much and it should be correctable. That bending should be correctable on stress. Second, the internal intrinsic ligaments like ACL and PCL should be intact. So these are the criteria for partial knee replacement, and it should be predominantly anteromedial arthritis. So these criteria should be there, and then only we can do partial knee replacement. The benefit of partial knee replacement is that the implant is much smaller than total knee replacement. it is minimally invasive surgery and recovery is faster. Now there are certain disadvantages also. Now what are the disadvantages of partial knee replacement? The disadvantages are because the implant is small, the surface area of small, and the body weight is same. So the pressure on the implant, which is force by area, force per unit area, is immensely more than total knee replacement. The stress on the implant is immensely more than the stress on partial knee replacement implant is more than total knee replacement implant, because the area is small, the implant is small, and hence the chances of something going wrong are still there with partial knee replacement. What it means is that probably total knee replacement is more predictable than partial knee replacement, probably. And when it comes to our country, like the Indian subcontinent, majority of the knee arthritis patients already have bending at knees, which is known as deformity, rigid deformity. That means it is not correctable, like varus deformity, which is known as inward bending, or bending onto itself, fixed flexion deformity. So in those cases we cannot do partial knee replacement, because we cannot realign the rigid bending of deformities of knee in partial knee replacement. That realignment we can do only in total knee replacement. So several cases total knee replacement is more predictable than partial knee replacement. Normally one side knee replacement takes around 20 to 30 minutes. So that depends on the expertise of the surgeon, how many surgeries the surgeon has done, the team, the expertise not only of the surgeon but the whole team. And the more the number, like I and my team, we have done more than 10,000 joint replacements. So for us it takes around 20 to 30 minutes on one side, and we prefer to do both knees in single sitting if the bending is there. So of course we can do one by one also, but we prefer to do both knees in single sitting. Well, this is a very important question, because many in our society, many, even the doctors tell that person should be older, person should be old to undergo knee replacement. We have to wait for, even if the symptoms are persistent, we have to wait till person gets older than 60 years for knee replacement. This is something very wrong. What I am trying to say is this is a very wrong concept. Knee replacement is done for advanced arthritis of knee irrespective of age, because the goal of knee replacement is to restore painless and stable movement, to restore professional and social life when a person needs it most. So if a person, for example, there are certain kinds of arthritis which can start at very early in age, like juvenile rheumatoid arthritis. They can start at 15 to 20 years of age. And in that case, the youngest person whom I have done knee replacement was 27 years of age. Someone called someone suffering with juvenile chronic arthritis or juvenile rheumatoid arthritis. I have done knee replacement at 27 years of age. I have done knee replacement at 29 years of age. I have done knee replacement at 31, 33 and 35 years of age. So all these people needed knee replacement. Now, for example, let's try to understand that if somebody who is having very severe arthritis of knee at 30 years of age, if you tell them that you come at 60 years of age, then the whole life of that person will be over. The person cannot lead a productive, socially and economically productive life, because the most productive years of a person are from 30 to 60 years. So we have to understand this, and we have to do knee replacement in very severe arthritis of knee, even if it is at a younger age, like 30 years. So because we have to restore the painless and stable movement in the productive years of life, most productive years of life. For example, I personally remember the lady whom I did knee replacement at 29 years of age. She was suffering from juvenile rheumatoid arthritis. The whole knee joint and one elbow and one knee joint was completely fused, and it was bent and fused. So after my surgery, she got married, she completed her MCA, and she is doing her job. Now, if I would have told that you wait till 60 years, her life would have been over. She would not have been able to join a job. She would not have been able to complete her degree. Productive years of the valuable years of life would have been lost. So we have to understand that any joint replacement benefits most for a person who is active, a person who is active and still in productive years of life. So now one question comes, that what will happen after 30 years? What is the expectancy of a knee replacement? What is the implant survivorship? Now, of course, because it's a prosthesis, it has got a survivorship, and that survivorship will be around average of 25 years to 30 years. So person who is undergoing knee replacement at 30 years probably will have to go another once again. The person has to undergo surgery at 60 years of age, after 25 to 30 years. So the person most probably will have to undergo one more knee replacement surgery at 55 or 60 years. A person who has undergone knee replacement at 30 years of age probably will have to undergo one more knee replacement at 55 to 60 years of age, and that is known as revision knee replacement, which is equally successful. Revision knee replacement is very established and equally successful. So knee replacement can be done for the second or third time. The knee has survived for 25 to 30 years, or even if something has gone wrong, it can be redone, and that is known as revision knee replacement, and that is equally successful as the first time knee replacement, which is known as primary knee replacement. Well, there are risks in almost everything. Even if you are walking on road, there is a risk that a vehicle may come and hit you. So if you are flying in airplane flight, there is risk that something can go wrong. If you are traveling, driving a car, there is risk that something may go wrong. So there is probably risk in everything, but it all depends on the care and the expertise of the team. For example, if the surgeon and his team, his or her team, they are doing this surgery daily in and out. The whole team is trained, motivated, and has developed a cumulative expertise, so that complications do not occur, generally do not occur, but sometimes yes, 1 in 1000 it can occur, but generally we take every care so that the complications do not occur. That's what we think. We take care so that complications do not occur. The results are very, very predictable, and we are successful in restoring the joy of movement back to you. Of course, there are certain complications which can take place in 1 in several thousands, like there is deep venous thrombosis, there is pulmonary embolism. So we use blood thinners called Klaxon for that, or we use low molecular weight heparin to prevent deep venous thrombosis. We do early mobilization, that is, we start the movement and physiotherapy on bed mobilization from the day of surgery itself, and from the very next day we start out of bed mobilization. That means we make the person walk from the very next day of surgery. So that is something which prevents deep venous thrombosis. We are very meticulous to take care so that no infection occurs, and in our series of more than 10,000 knee replacements, almost everyone has been very, very successful and very, very pleased after knee replacement surgery. No, not. Knee replacement is not supposed to affect your hip. Well, actually knee replacement doesn't cause restless syndrome, but there is some amount of discomfort in legs can be there for some people for very short amount of time. What we need to understand is that the knee prosthesis that we put in after knee replacement is a cemented prosthesis. That means that it is put with something called bone cement, and that becomes strong immediately. Within 10 minutes the bone cement sets in, and it consolidates, and it gains its maximum strength right in the operation theatre itself. So we allow full weight bearing from the very next day. But there are 2 or 3 aspects. For example, the muscle strength development is an aspect. For the body to adjust to that implant is an aspect which takes around 1.5 to 2 months. So during that time there can be some amount of redness, swelling, heat. There can be some amount of restlessness in legs, especially at night. So we do give some medicines for this neuropathic feeling, and we give medicines like pregabalin, amitriptyline in very low doses, so that person is comfortable. And the whole muscle strength development exercises after knee replacement is very, very important, and it takes around 1.5 to 2 or sometimes more for the full muscle strength to develop, for the body to adjust to the new implant. So it takes some time, and during that time we take care of you completely, so that you do not have any discomfort, so that you do not have any sleep disturbance or any discomfort or any unpleasant time. So we take care of it, everything. No, no, no. It is absolutely not possible. Several times what happens is that people who are undergoing knee replacement, they also have degenerative spine disease. They have also lumbar spondylitis, and they already have neuropathy before knee replacement. So sometimes people have radiculopathy. What it means is that the spondylitis in spine, the pain gets referred to legs because nerve roots descend like that. The nerve roots descend like that, and that is known as referred pain. The degenerative back pain gets referred to legs, so that is known as radiculopathy. So that is an independent thing that we need to take care, and we do take care of it. And sometimes people, especially diabetic, may have some distal neuropathy, already pre-existing neuropathy, but this is not related at all with knee replacement. This is an entirely different thing, and we need to take care of it, and we will take care of it. Well, there is nothing called maximum age. We need to understand that this is a surgery to uplift one's quality of life, to restore painless and stable movement. So we have to do this surgery in a person who is still mentally and physically active, mentally active especially, and we need to establish one's fitness for surgery. So for that we need to check the body functions, like we need to check blood test, we need to establish the liver function, kidney function, thyroid function, heart function. So most important criteria for surgery is a good heart and kidney function, because we give fluids or blood after surgery, and that leads to hemodynamic changes. So there should be good heart and kidney function. So there should not be gross neuropathy, and heart should have reasonably good function in echocardiography. So these are the things that we look for. It's not about the calendar age. It's not about the calendar age. It's about the physiological age of the person. Well, personally speaking, I have done, the senior-most person whom I have done knee replacement was 88 years of age, and the youngest person whom I have done knee replacement was 27 years of age. So either way, we have to balance things. And as far as age is concerned, we need to look at the physiological age, the organ functions of the person, like the kidney and the heart function, the most importantly. We need to understand that the implant that we put for knee replacement, the prosthesis, the implant that we are using, that's a cemented implant. It is put on the bones, it is fixed on the bone ends or the surfaces with something called bone cement, which fixes it, sets in by polymerization reaction, and that is over in 10 minutes. So implant is at its maximum strength right in the operation theater itself. So we are able to mobilize the person out of bed, full weight bearing. That means the person puts full weight on his feet and starts walking from the very next day of surgery. For support, we have to use a walker for first few days, or let's say first few weeks, and then in a couple of days the person is able to go to washroom, sit on commode. Initial few days we can raise the height of the commode so that it's easy for the person to get up, and the person is able to sit on chair and all, and by the time of discharge one is able to climb few stairs with support. That is possible. When a person goes back home after discharge, one is able to walk in the home, one is able to go to washroom, take care of himself or herself, sit on commode, sit on chair, and all these generalized activities one is able to do. Of course, first few days or first few weeks we need a walker or a crutch to support that person, and then we start rehabilitation, that is physiotherapy, from the day after surgery itself, or from the day of surgery itself. We start first on bed mobilization, we start quadriceps strength building exercises, and the full recovery takes around 1.5 to 2 months, because the muscle building, the quadriceps strength building is of paramount importance. It's very important, the quadriceps strength building, and for the body to adjust to the new implant, because it's a foreign body, there is some inflammatory response which is characterized by some amount of redness, swelling and heat, and that stays for around 1.5 to 2 months. So full recovery takes place 2 to 3 months. So one is able to join office by 1 to 1.5 months. one is able to go outstation on tours after 2 to 3 months. So full recovery takes place after 2 to 3 months. Obesity is a problem everywhere, but obesity does not have a direct impact per se on knee replacement. What I mean to say is that, like for example, the heaviest person whom I have operated was both knees was had been like 138 kgs. So obesity is not good for anybody, and weight reduction is very important. But obesity doesn't have a direct bearing on knee replacement as such, and we have been doing knee replacement for many obese patients also, because it's a paradox, because until and unless person walks, the obesity will not come down. So we do knee replacement, and we always encourage the patient to walk more and more from the day of surgery, walk more and more, so that there is weight loss. And many people have been able to do weight loss after knee replacement surgery by walking, because restoration of painless and stable movement is very important. And if a person is not able to walk, not able to move, then the weight gain comes as a vicious cycle. So we have to break this vicious cycle by enabling a person to walk. And once a person is able to walk, we encourage him or her to walk more and more, and thus reduce the weight. Well, the single most important factor for the survivorship and the longevity of the knee replacement implant is the surgical precision, because the bone resurfacing should be at correct angles, the implant placement should be at correct angles. It's the degrees and the millimeters that are more important than any brand of the knee. The brand of the knee should be standard, but it doesn't have any bearing, because you use brand A, B and C, or C, it doesn't matter as far as the results are concerned, if the surgical precision is accurate. Because it's all mechanics, the surgical precision is of paramount importance, hence the surgical skill of the surgeon is of paramount importance, and the surgeon is of paramount importance. The motivation of the patient is also equally important, because for a person to go back to normal life, the person should be motivated, should motivate himself or herself to do exercises and go back to normal life. And other things that we need to take care of about the longevity of the implant is that we should avoid high impact activities after knee replacement. For example, jumping, skipping, running should be avoided. Sitting on ground regularly should be avoided. Squatting should be avoided. Although sitting on ground sometimes can be done as on a very rare occasions or in emergency or very special occasions, but it should generally be avoided to prolong the life of the implant. If one is sitting on ground regularly, if one is squatting regularly, if one is running regularly with the knee replacement, it may decrease the survivorship of the implant. A knee replacement is the treatment for end stage arthritis, for advanced arthritis, when there is bending at knees and the person has been being troubled because of knee pain or instability for months together or years together. Knee replacement is not done in early arthritis. In early arthritis, we always promote muscle building exercises, muscle strengthening exercises, which is quadriceps drill. Muscle strengthening exercises are of paramount importance. We advise activity modification, lifestyle modification. We advise weight reduction, because more the weight, more is the pain. So reduction in weight helps to reduce the pain. And we also advise certain dietary supplements like collagen peptide, glucosamines and all. So once it is advanced arthritis, once the knee has started buckling or there is instability, there is continuous pain, I don't think there is any other alternative to knee replacement. So to answer this question, probably there is no alternative to knee replacement. Yes, if you are suffering from knee arthritis which is affecting your professional, social, personal life, or which is affecting your activities of daily living over a period of time, over a period significantly large period of time, like nobody does knee replacement for a pain of few days or few weeks, but if it is for months together or years together and it is affecting your activities of daily living, it is affecting your social or professional life, then yes, at 40 years of age you can undergo knee replacement. As I explained earlier, the youngest person whom I have done knee replacement was somebody who was suffering from juvenile chronic arthritis, and knee replacement was needed at 27 years of age. or another lady I have done was 29 years of age. So whenever there is requirement, whenever there is advanced arthritis which is cause crippling pain and bending, which is known as deformity, there is bending at knee which leads to instability, disbalance while walking, increases the risk of fall, then we have to undertake knee replacement to restore painless and stable movement. Because we must need to understand that the period from 30 to 60 years is the most productive years of life. And of course, if somebody has to undergo knee replacement very early in life, then there are chances that after 25 to 30 years there will be need for second surgery, which is known as revision knee replacement. But well, then revision knee replacement is also equally successful and it is a well established surgery. So knee replacement can be done for the second or third time also, and that is a very successful and well established surgery. The exercises after knee replacement, the single most important exercise is quadriceps strength building exercise, because quadriceps is the guardian of the knee and the quadriceps has to be very strong as possible. So you have to build up the strength of the quadriceps muscles by doing quadriceps drill. We have to do hamstring stretches to straighten the knee, and of course knee bending. Knee bending after surgery exercises has to start. Before and after exercises you can put cool packs or ice compress, which will make a person more comfortable during or after the exercise. And these predominantly three types of exercises are there. Along with that, we have to do hip abductor strengthening exercises, so for normal walking, because the walking gait is a coordination between the ankle, the knee, the hip and the back. So it's 3-4 joints are involved in that, 3-4 body parts are involved in that. So we have to do exercises for all these 3-4 body parts, but single most important exercise is quadriceps muscle strengthening exercises and knee bending exercises. Yes, of course. Bilateral knee replacement, what it means is that we do both knee replacements. We do the both sides knee replacement in single sitting in one surgery. Well, I think it is a good idea when both knees have to be replaced. When both knees are bent like this, then it's good idea to replace both the knees in one go. Because if you replace one knee, this will become straight and other will be bent. So there will be limb length discrepancy, which will again lead to instability. And if a surgeon who is doing one knee replacement on one day and after 3-4 days he is doing another knee replacement, or after 5-6 days he is doing another knee replacement, then it becomes two surgeries. The person is being operated twice. The person has to undergo anesthesia twice within a gap of few days. So the person's body is undergoing hemodynamic stress twice within a gap of few days. So it's better than that to do in single sitting, because when I prefer to do in single sitting. When I do in single sitting, even though both knees are getting operated, but medically and physiologically it's one surgery. We are giving anesthesia only once, we are giving IV fluids only once, so our body is undergoing hemodynamic changes only once. So it is safer than giving a gap of few days, which is known as bilateral staged knee replacement. So single sitting is a good idea, but yes, of course, before doing single sitting both knee replacements, that is known as bilateral knee replacement in single sitting, that means both knee replacements in single sitting, we have to establish one's fitness for surgery. There's the reason, the hemoglobin, the blood amount in the body, the hemoglobin should be reasonably okay, the heart and kidney functions should be reasonably okay. So these criteria are there, and if the person's reports are reasonably okay and we have established the fitness for surgery, we can very well do both knee replacements in single sitting, and this is a very safe procedure, and this is known as bilateral simultaneous knee replacement. Yes, of course, we take care of safety first. We establish one's fitness for surgery, then only we go ahead with the surgery, because knee replacement is not a life-saving surgery. It's a surgery to uplift quality of life. So we will never take enormous amount of risk for the surgery. So first we establish one's fitness for surgery. If needed, we wait and optimize the patient. We optimize the patient before surgery, then only we do surgery. So safety is of paramount importance. We do pre-anesthesia checkup, pre-anesthesia assessment, then only we proceed for surgery. So safety first, then only we do surgery. So knee replacement is very safe surgery. Yes, that this is what we were discussing earlier also. The first knee replacement is done known as primary knee replacement, and if the implant has lived for 25 to 30 years, then we may need to do surgery for the second time also. That happens generally in very young patients. Like if somebody has undergone knee replacement at 30 years of life, 30 years of age, then after 25 to 30 years, when the person is still 55 to 60 years, there may be need for another knee replacement second time, which is known as revision knee replacement. So it can be done twice or even thrice, and in very rarely sometimes if there is any problem with the first knee replacement or there are any complications, then we may need to do it again, which is known as it can be redone and it can be corrected. Even if there is some problem in the first one, it can be corrected. Or if somebody's knee has lived for 25 to 30 years or 35 years and there is need to redo it, it can be redone. That is known as revision knee replacement. So knee replacement can be done for the second time or even third time, and it is very much possible to correct all the issues in the second time, and it is very much possible to do a very successful revision knee replacement. Well, I don't think so. I don't believe in that. A person must be admitted, because on the day of surgery and a couple of days after surgery, the person must be under care of the doctor, and hence the patient must be admitted. We cannot do as outpatient surgery. I don't think we can do as outpatient surgery. Yes, of course, knee replacement is the gold standard treatment for any end stage arthritis, whether it be osteoarthritis, rheumatoid arthritis, juvenile chronic arthritis, or ankylosing spondylitis. But as far as the rheumatoid arthritis is concerned, we need to understand that knee replacement will solve the problem of the knee. Like if the difference between osteoarthritis and rheumatoid arthritis is that osteoarthritis is a localized disease. For example, if a person is having osteoarthritis of knee, the other joints are okay. The joints in fingers, hands, or the hip is okay. But rheumatoid arthritis is a systemic disease and it's a polyarthritis. What it means is that if knee is affected because of rheumatoid arthritis, several times fingers would also have been affected, or hand also would have been affected, ankle may have been affected, hip may have been affected, shoulder may have been affected. So we need to understand that knee replacement will completely solve the problem of knee, but it will solve the problem of knee only. It will not solve the problem of hip or ankle or hand arthritis. So we need to understand that very clearly. So in rheumatoid arthritis, one may need to keep on taking medicines for rheumatoid arthritis even after knee replacement for other joints, not for knee but for other joints. Yes, this we have already discussed. I generally prefer to do knee replacements on both sides in the single sitting if a person's knees are bent, because that way we will have the person will be able to walk freely from the very next day of surgery. And I prefer to do in single sitting rather than giving a gap of few days, because when one gives a gap of few days between two surgeries, it becomes two surgeries. It becomes you have to give anesthesia twice, and the patient undergoes hemodynamic stress of surgery twice. So it's better to do in one sitting. If we do in one sitting, even if we are operating both sides, but medically and physiologically it is one surgery. So I prefer that, and I think that is a better way of doing rather than giving a gap of few days. But yes, of course, that depends on the team, the expertise, the speed. For example, for us, we have done more than 10,000 knee replacement. We finish a knee replacement in 30 minutes. So both sides takes around 1 hour. But if the team takes a much longer time to operate one side, then it is not possible to do both knees in single sitting. So all these things are there, and multifactorial things are there. And when one's knees are bent like this, if we do one knee and leave it, then one knee straightens and the other knee is still bent. So there will be discrepancy in the limb length, that is the length of the legs, and that will again lead to instability. So the process is eventually complete only after the second knee is also done, whether you do it together or after a gap of few days or few months. But if both knees replacements are needed, of course, even if only one knee is needed, we will do only one knee. If one knee is needed, we will do only one knee. Why should we touch the other knee? But if both knees are needed, then it's a good idea to do both knee replacements in single sitting. Of course, before that we have to establish one's fitness for surgery. The reports, the blood levels, the hemoglobin, heart and kidney functions have to be reasonably okay. Well, traditionally the alloy which has been used in knee replacement is, on one side it is cobalt chromium alloy, and other side that is known as the bearing surface, the articulating surface in a knee replacement or any even hip replacement. The traditionally on one side is cobalt chromium. The reason cobalt chromium is used is because cobalt chromium alloy can be most highly polished, and other side is ultra high molecular weight polyethylene. So this bearing surface of cobalt chromium on one side and ultra high molecular weight polyethylene on other side gives a very minimal friction and gives some amount of shock absorbing capabilities also, so that if a person is running, that will not lead to failure. Now recently this cobalt chromium some companies have come up with coating of titanium niobium. Titanium niobium is a metal alloy and it behaves like a more inert material, ceramic material, is supposed to be scratch resistant and all. So this titanium niobium is golden in color and hence it is called gold knee. So it is not gold, it is actually titanium niobium. But as I told you, these things are not very important, because the most important thing is the surgical precision, the accuracy of the surgery, the mechanics, hence the surgical expertise of the surgeon is the single most important. The technique, the modality that we use is known as painless knee replacement. How we achieve this? During the surgery, we give regional anesthesia, which is spinal anesthesia or some other regional anesthesia, and before the surgery itself we use something called nerve block. What it means is that the selective sensory branch of the nerve from the knee joint, the sensory nerve supply of the sensory nerve from the knee joint is blocked by using a local anesthetic and seeing under ultrasound. So this is known as nerve block technology. We block the femoral nerve and we block the adductor canal, the saphenous nerve, which is the selective sensory nerve of the knee, and thus we close the gate of pain. This is we close the gate of the pain before the pain comes. So by and large it is painless. Along with nerve block, we also use multimodal analgesias like patient control analgesias, transdermal patch and medicines. So by and large things are very painless, by and large things are very comfortable, and it is not painful at all. Generally we use local anesthesia, better known as regional anesthesia. We use spinal anesthesia along with the nerve blocks, and the person may prefer to be awake. We if the person is awake, the person may listen to songs. If the person wants to sleep, we give the person some amount of sedatives, like short acting sedatives like midazolam, and the person just sleeps off. And this is normally what we do. And general anesthesia normally is not given until unless the person, one undergoing surgery, prefers general anesthesia. If a patient prefers general anesthesia, we will give general anesthesia. Well, this is concern which almost everybody who is undergoing knee replacement has. Let me tell you, it is a very predictable surgery, almost guaranteed results, and it is a very successful and life-changing surgery. It all depends on how carefully we are doing the procedures, how many we are doing the procedures. So we are doing this surgery in and out, day in and day out. So not only the surgeon, the whole team is trained and the whole team coordinates in a very coherent manner and makes the results very predictable. We take care of all apprehensions, we take care so that no complications occur. We ensure that the results are very predictable. And even if something goes wrong, God forbid if something goes wrong, then it can always be recorrected. Knee replacement can always be revised, and it can be redone, it can always be redone. So even if something goes wrong, it can always be redone and we can restore normalcy again. We have already discussed this. No, knee replacement cannot be done as a keyhole surgery. It's not an arthroscopic surgery. It is minimally invasive surgery. That means the muscle is not cut and it is a muscle sparing surgery, but it cannot be done as a keyhole surgery as such. because we have to put this big implant, so it cannot be put through a keyhole. So minimum it has to be 2 to 3 inches of incision has to be there. Normally it's a centrally placed incision, and in minimally invasive surgery it's a quadriceps sparing surgery, wherein we do our procedures beneath the muscle without cutting the muscle, without disturbing the strength of the muscle. So the recovery is fast and accelerated recovery, and one starts walking from the very next day of surgery. No. There are no lasers that are used in knee replacement, and it's not a keyhole surgery. Present knee replacement is very affordable, very within the reach of almost everyone, because we have the cost of knee replacement as such has come down, because the cost of implant has been capped by the National Pharmaceutical Pricing Authority. The cost of the implant has come down, and not only that, there are multiple insurances which have come up, private as well as state government insurances, the government insurances. It is very much affordable now, and as far as the cost is concerned, we always ensure that nobody who is willing to undergo knee replacement is never turned down because of cost. We arrange things, we make them make it very affordable, so we take care of it, and I don't think anybody who needs a knee replacement will not be able to do it because of cost as of now. Especially if it comes to us, we will always help the person out, so that a person who needs knee replacement and wants to undergo knee replacement is never hindered by the cost factor. Well, almost all insurances support knee replacement. The private insurances, government insurances, they all support knee replacement. And certain insurances, they have a policy that the insurance should be at least 2 to 3 years old for them to give for knee replacement. So all those things are there, but most of the insurances do support knee replacement, and our hospital, our setup, our team, our institution gives cashless facilities to everybody. Everybody who is covered by insurance will get cashless facility. For people who are coming from outside, we always give them a warm welcome. We give them time as per their choice. We give them appointment as per their choice. We arrange for their stay, local stay, and if needed, a person can, even after being discharged from hospital, can stay locally for few more days for rehabilitation and stitch removal if needed. So we arrange for everything. If somebody needs an appointment letter to get visa, especially from neighboring countries, then we send appointment letters, we make them get visas, and we arrange everything so that person has a very memorable, pleasurable and warm stay over here, right here in Kolkata, and accommodation and all, we arrange everything. Well, the system that we use is orthopilot navigation. It's a computer assisted system. It's very precise, and it allows you to plan the surgery. It allows you to plan the surgery well, and it selects the sizes of implant, placement of implants, and the 4th generation navigation system. And as we discussed before itself, that the single most important thing in this knee replacement surgery is precision. It's not about the brand of the implant, it's about precision, because it's all physics, it's all mechanics, and navigation definitely, orthopilot navigation definitely improves precision. Well, I can tell you that we will give you the best and the safest and the most predictable results at the most affordable prices, and we are always eager to welcome you, and we will arrange, we will help you in getting visas, we will help you in getting staying here locally, and we will make sure that you get the best, the safest at the most affordable price. So we will take care of all other aspects of the treatment as well. Thank you.